Very early in this pandemic, it became clear that the light at the end of the long tunnel was vaccines. Putting that into operational effect, however, has proved to be a much more complicated endeavor. From the race to create effective vaccines in record time, to procurement, and now rollout into the arms of Canadians. None of it can happen fast enough, of course, but let's look back and ahead at the effort. We welcome, as is our custom on this program, we introduce from furthest away to closest to our studio, starting in Vancouver, British Columbia, with Colijn, Professor and Canada 150 Research Chair in Mathematics at Simon Fraser University. In the nation's capital, Taylor Vaisey, Associate Editor for Maclean's magazine, and in the provincial capital, Dr. Isaac Bogoch, infectious diseases physician at the University Health Network and a scientist based out of the Toronto General Hospital and the U of T. And Dr. Bogoch, good to see you again. And Carolyn and Nick, good to have you on our program, I think for the first time for both of you. Nick, you've been here before?
I have not. No,
I didn't think so. No. Okay. No, good to have you here. Let's start with a chart. Charts are always very helpful in this regard. Sheldon, you want to bring this up? Thank you. This measures confirmed orders of vaccine doses per person for last year. And Canada is number one. We confirmed a great number of orders per person in the world. Australia comes second, Britain, the United States comes further down, the EU, and so on. This is not obviously the whole story, but it is part of the story, and we will start there. Nick, come on in here and tell us, because back in November, we looked pretty good in terms of vaccine procurement, but now it's early March of 2021, and it's a bit of a different story. How did we become the country with the most procurement in the world?
Well, you had a very busy team of procurement folks in Ottawa negotiating with all of the leading candidates around the world, and frankly, competing with countries that offered much larger bases of customers, and also continental blocs like the European Union. And they came up with all these different agreements that amounted to almost 400 million vaccine doses, which, as all of your viewers will know, is many more doses than there are Canadians, even when you account for the two-dose nature of so many of these vaccines. So they spent most of the summer negotiating with these companies.
So would you call that kind of the good news part of the story?
I would say that the agreement with Moderna and the agreement with Pfizer were two of the first to be signed with those respective companies around the world. The other agreements came later, and when we start to have debates about where Canada is in line for all these vaccines, I think there's a really good argument that Canada is near the front of the line, if that's even an appropriate way to put it, with Moderna and Pfizer. With the other companies, it's a little less clear because those deals did come a bit later in the process. Okay.
Dr. Isaac Bogoch, let me get you to react to that. The notion that last year, when this was all ramping up, Canada was actually at the, again, an unfortunate expression, but was at the front of the line for countries around the world securing doses. What did you think at the time?
Oh, I thought it was fantastic, given that at that time we don't have the capacity to mass produce or make those vaccines locally at that time. And we were going to be relying on foreign companies in foreign countries to get these vaccines. I think they did the right move by putting together a task force to really bet on potential winners. Remember, this was before we had the results of a lot of the clinical trials. And they ended up putting their money down on several winners, right? Pfizer, Moderna, AstraZeneca, Johnson & Johnson, Novavax. Like, these all ended up being really good vaccines when we saw their phase 3 clinical trial results. I'm sure we'll hear more about what transpired since then, but those are 5 very solid vaccines.
Okay, Professor Colijn, how about from your vantage point? How did we look back in the day?
Yeah, so we did get a little bit of a bad rap in terms of, ordering so many more doses than we have people in the international context when some countries have not had access. But of course, as you heard, we didn't have the results of phase 3 trials at that time, and I think they were doing the best that they could to protect Canadians. Now, I guess it's a question of the contrast between that chart and the relatively slow rollout that we've seen. But I think, of course, securing the doses, will be the cornerstone of our way out of the pandemic. And so it's very natural that they would do that in advance of even having the data about how the vaccines will perform.
Well, you've exactly put us in the direction we want to go next, and that'll take us back to Nick, because yes, even though we appear to have done very well on procurement compared to other countries around the world, we note that the UK has 20 million vaccines already distributed, 13% of its population in the United States already vaccinated, Canada less than 5% of its people vaccinated. How did we go to doing so well initially to being so poor when it comes to actually getting needles in arms?
Well, I think we've already touched on it a little bit here, and it's largely because we're relying on foreign-produced vaccines. So we have vaccines that are being produced in European plants. And then, of course, there are vaccines being produced in American facilities, but the United States has reserved all of those doses for Americans until the American population is fully vaccinated. So it was the lack of a domestic option, which was the matter of some debate for some time as the country kind of learned what biomanufacturing capacity really is and what it would take to produce these specific vaccines, which are not things you can just sort of put in a queue and have somebody produce in a matter of days. I mean, these are complex products, and so the lack of a domestic option was a huge wake up call, I think, for a lot of Canadians who might have assumed that there were facilities in Canada that could just produce these rather quickly.
Okay, Isaac, talk to us about that part of the story. Why do we not have more domestic production in this country?
Yeah, well, I mean, it's a long story, but the punchline is this really involved years and years of investment to support and maintain that infrastructure. And for years and years and years, we just didn't pump in the money or the requisite support. I think, obviously, this is a health security threat. It's pretty obvious now. You have to be able to produce vaccines locally, basically, given the circumstances that we're all under now, that's abundantly clear. And you've seen a pivot from the federal government. So, for example, there's a plant now in Quebec that's going to be manufacturing the Novavax vaccine. But as to a few points that were made earlier, it's not like we had zero capacity locally. We just had minimal capacity locally. And now there's a clear recognition that that's extremely important. And you're starting to see investment in that. So, for example, the plant in Montreal is going to be producing Novavax, but also there's homegrown small Canadian startups and small Canadian companies that are, developing vaccines and conducting clinical trials. For example, we have a company in Canada that's developing their own mRNA vaccine. So we obviously need to support our local scientists, our local companies, and our local industry to produce these vaccines locally.
Carolyn, why did it back in the day not happen?
So that's, I think that funding picture is part of the story and the investment. And I think, infectious disease researchers would always talk about, what happens when the pandemic comes. We had a flu preparedness plan. We had planning after SARS. But at the end of the day, a major infectious disease event like this one doesn't happen that often. And public health is not that exciting. It's not. Of course, I think it's very exciting, but it's a little harder to sell preventing the problem that you don't have yet than it is to sell solving a huge problem that you do have. So opening a new building or whatever is more direct, more concrete, more tangible. It has a name. You can have a donor with a name on it. Whereas preventing a huge problem that you don't have is a much harder motivation. Hopefully now, recognizing that in the last 2 decades, we've seen SARS, MERS, Ebola virus, Zika virus, H1N1 flu, and now, of course, COVID-19. Maybe we will start to think about public health capacity and health security in a more proactive way and make sure we have those investments. There are companies in the prairies in Alberta. There's Providence Therapeutics. There are companies that mentioned in Quebec that can build this capacity. But I think, we want to make sure vaccines are safe. This isn't something you roll out in a day. You need accreditation. You need the facility to be making exactly the right thing. You need all the protocols in place. So I think, that's something on a year time frame or more, not on a 6 weeks time frame. And unfortunately, it's the next 3 to 10 weeks, 3 to 20 weeks where we really need to be vaccinating Canadians to get out of this pandemic if we don't want to keep going with the measures we have for many more months.
Isaac, just follow up on that part of the story, if you would, in as much as do you think we're now making the right decisions to ensure adequate domestic production in Canada?
Yeah, I think it's a very, very good start. But of course, it's not the end of the story here. So for starters, local companies that are producing vaccines are being supported. I think there could be more to support even before that process starts, and support local scientists and vaccinologists in the preclinical work that's done. And then, of course, you've got to support industry. So, for example, we have the plant in Quebec that will be producing the Novavax vaccine. Certainly that's a start, but of course, it's not the end of the story. We just need to expand on that. But yeah, those are arrows pointing in the right direction. And as Dr. Colijn just pointed out as well, we need vaccines in arms now. And of course, supporting those industries and supporting those scientists is a medium-term to long-term plan. Our short-term plan is really still going to be get as many vaccines as we possibly can from foreign companies in foreign countries so that we can vaccinate the local Canadian population.
Okay, we got another chart here. And Nick, I'm going to ask you to take us through this chart. Sheldon, why don't you bring this up? This is new vaccine deliveries in Canada. And I'll describe it in some detail for those listening on podcast who can't see all these bars. But essentially, we go back to last December. And we can see that there is some vaccine being delivered to Canada. We go along to January 10th, January 17th. And then all of a sudden, January 31st, late January, and there's nothing. There is no vaccine delivery coming into Canada at all. Now, in February and towards the end of February, we're getting much more significant doses coming in. But Nick, you got to tell us, what happened in late January where we got nothing at all?
So in mid-January, the federal government said they heard on pretty short notice from Pfizer that the company was retooling its Belgian plant. So that is the plant where Canada is sourcing its vaccine doses from that particular company. They have a plant in Kalamazoo, Michigan, which is just so close to Canada, but of course is wrapped up in the American vaccination effort. So as that plant was retooled to actually produce even more doses in a year, into the billions, the company said it was shutting down slowing down production lines. And that had an impact on every country that was receiving doses from that particular factory. Pfizer said that the distribution would be equitably reduced. Of course, Canada got 0 doses, as your graph shows, pretty starkly. And other European countries never seemed to reach quite that level, to the point that there was nothing. But then at the same time, Moderna, the other approved vaccine in Canada, only ships on a every 3 week basis. And so that particular week when Pfizer deliveries went down to 0, Moderna wasn't scheduled to make any deliveries. So their supply was stable, though it also later was reduced a little bit. But that particular week, there was nothing. But as the graph shows, it has started to ramp up, and it will continue to do so well into the future, into the summer.
But I just want to confirm this, Nick. To your knowledge, no other countries anywhere in the world got down to 0, but Canada did.
Not sure if the number is that no other countries got to 0, but the peer countries that we often compare ourselves to in the European Union never seem to get to that point.
Okay. Isaac, the bars on that graph thankfully went up as we went towards the end of February and we started to get more supply. What can you tell us about where we are today on that front?
Yeah, so for starters, when those bars went down, I got to tell you, those were some tough times. I think anyone who's involved at the federal level or at the provincial level or at the municipal level with anything vaccine related was having a very challenging time. And of course, I know the general community was as well, because that was, you're not getting any vaccines. And basically, our pathway out of the pandemic hinges on those vaccines. So it was a pretty precarious time. But Pfizer said, they were transparent the whole time. They said, we're going to shut down or decrease production for a few weeks while we retool our plant so that we can make 2 billion doses instead of 1.3 billion doses in the 2021 calendar year. And that's exactly what happened. They slowed down for a few weeks and then they ramped back up. And now we're getting actually more vaccine than we anticipated, and we're getting it earlier than anticipated. So that's kind of where we are now. But the month of March is going to be very interesting. We're in this period of time where we're seeing a scale up of the vaccine that's delivered to Canada, but we're not really at the massive inflection point. That massive inflection point is really going to come as March turns into April, and that's when we're going to see the taps really turn on. And that's when you're going to see a massive expansion of the vaccine distribution programs from coast to coast. So, now it's being offered, for example, in maybe there's a few mass vaccine sites that are set up or clinics that are being set up to administer this. But as March turns into April, we are really going to see significantly more vaccines coming into the country, and you're going to see this profound expansion of those programs. Drive-through sites, mass vaccine sites, community centers being used as sites, pharmacies administering vaccines, primary care providers administering vaccines, and on and on and on. So I'm pretty excited about that. But of course, we have to skillfully navigate the next several months, because we still need to vaccinate a significant proportion of Canadians as quickly as possible.
Right. And until those vaccines all come in, Carolyn, let me bring you back in here now, because I wonder if you can comment on this notion. There were lots of people, a lot of opposition politicians in particular, who were saying during this period of time when we were getting no vaccines in at all, they were saying, well, come on, Justin Trudeau, just pick up the phone and call some corporate executive and make them send us some. Now, I don't know how this world works, but does that kind of thing help?
I can't imagine that it would, honestly. If one phone call could procure vaccines, surely everyone would be doing that, everyone in the whole world. And maybe they are all doing that, and that's why one phone call doesn't procure vaccines. To me, I think, that delay was, obviously, as commented, very stressful for people involved in the vaccine rollout. But I think Canadians should be aware that right now, most of us are not being impacted by vaccination unless, the people who are directly impacted are the right people, the people who have been very, very vulnerable, the long-term care, the healthcare providers, the very elderly. But that's not kind of denting transmission in your community and determining whether or not, you get to go out to a restaurant or visit your friends or family, because we're not at that inflection point yet where we're doing mass vaccination. So it's actually better for all of us to have a speed up of that general rollout, even though it took a week delay in January, in my opinion, because it's that general rollout that will be critical. And also that general rollout worldwide, those 2 billion doses. COVID in Canada and our life in Canada is not an island from the rest of the world. And so as we seek to reopen borders and travel, we also need people in other places to be vaccinated and to be protected along with ourselves.
Mm-hmm. And Nick, have you picked up anything in your reporting at all that would suggest that the rather optimistic and buoyant outlook just given us by Isaac Bogoch will not come to pass? Or are you quite convinced it will?
Well, I think, there's no proof that, or there's no evidence, or there's no suggestion that delays are going to be slowed down. And the only reason we might not believe that is that slowdowns have already happened. But as Isaac said, Pfizer was pretty transparent about the reason for that slowdown. And so the government has said, the federal government, that 4 million doses of Pfizer will be in Canada by the end of March, and 2 million doses of Moderna by the end of March. And it appears they're going to achieve that. The scheduled deliveries are on track, and then the ramp up will happen, and then we'll have that wider immunization program into the summer. There's no reason to believe at this point that there will be any more major disruptions.
Okay, good. Let's do one more chart here. And this one, again, I'll ask our director, Sheldon Osman, to bring this up. This is vaccine doses administered per 100 people. And again, for those listening on podcast, I'll take us through this. You've got in the Yukon, in Nunavut, and in the Northwest Territories, very high rates at the moment, approaching 80% in some cases. In Nunavut, more than half the people have had doses administered so far. But then there is a rather significant drop-off. Prince Edward Island, 7.8%, Saskatchewan, less than 7%, Manitoba, just over 5.5%, BC. Keep going. We don't get to Ontario until the fourth from the end. Fewer than 5% of Ontarians have had the shot so far. Newfoundland and Labrador, even fewer. New Brunswick, Nova Scotia, even fewer then. Okay, Isaac, come on in here and tell us about this province, of course, likes to think of itself as being a national leader in everything it does. Those numbers are a long way from being a national leader. What happened?
Yeah, so there's a few points. One is that, yes, of course, we could speed things up. And of course, there's always room to improve efficiency of vaccination. The second point is that when you look across those numbers, like the difference between, 4.8 and 4.9 or 4.8 and 5%, really isn't all that much. And the third point is that direct province-to-province comparisons are helpful to sort of frame a discussion, but when you sort of scratch the surface, there's a lot of differences that might account for such profound value between these. So, for example, credit where credit's due. Way to go, PEI. That's a wonderful value. But you imagine the logistics of vaccinating PEI might be a little bit different than logistics of vaccinating a massive province with 14 million people scattered all over the place in rural and urban settings. So I think those are the three key points I'd take away from a graph like that.
Well, okay, fair point. But on the other hand, the Yukon is a massive territory with a very tiny population. Nunavut, Northwest Territories, same situation. Big territories, small populations. They've somehow managed to get more than half, in some cases more than 3/4 of their population inoculated already. How come?
Well, obviously, credit where credit's due. There's nothing taking away from them for doing a wonderful job in vaccinating their population. But I think when you look at where their population is situated, many of them are in the main cities of those territories. So access is remarkable. I wouldn't say remarkably easy. It's easier to vaccinate when everyone's in one place. Of course, that's not entirely true, and I'm oversimplifying things, but that is a major component. The other is look at the volume of vaccines available per capita, and that might be a little bit different for some of the territories as it is compared to the provinces. But of course, logistics in terms of vaccinating a bulk of your population is going to be a little bit easier when everybody is within reach, rather than when you're going to have to vaccinate multiple cities, multiple towns, and even rural, remote, underserviced areas.
Okay. Nick, do you want to come in here and tell us why you think, and I take Isaac Bogoch's point that, the difference between 4.8% and 5.3% may not be all that much, but facts are facts, and the fact is Ontario apparently has the 4th worst rollout in the whole country right now in terms of comparing provinces and territories. Why would that be, in your view?
Well, I think it's worth pointing just a little bit at the territories and the reason those numbers are so high. The federal government and the provinces and territories collectively prioritize those populations for a whole lot of reasons. There are a lot of vulnerable, remote Indigenous communities. They've gone through epidemics in the past. Tuberculosis in the 20th century is one horrific example. And so those territories and the rollouts that they have executed are extremely impressive. I've talked to a whole bunch of people in Yukon, and they charter planes to communities that are 4 hours from Whitehorse, and they get 80% take-up during a 4 or 5 hour span of immunizing in that community. Old Crow is a particularly far north community. That's a fly-in place, and that community has now been 80%, as far as I've confirmed, 80% immunized. So that success kind of stands apart from the rest of the provinces. And Ontario, to speak to that complexity versus other provinces, particularly PEI, there is a lot of complexity. I mean, Ontario has its own rural and remote and Indigenous communities, and just a whole whack of people in a whole bunch of different situations. Not to excuse the effort, that number is low, and the other thing you can't do is you can't eliminate the anxiety people feel. That anxiety is real, and it's having an effect on our mental health and our lives. So to just say, well, it's tough, that's not going to be enough for anyone until it's over.
Carolyn, I wonder if you could help us understand the priority list right now, because obviously I've heard from lots of people who say, if you really want to make a dent in this thing, in COVID-19, go for congregate care settings first. So obviously long-term care, homeless shelters, prisons, that kind of thing. That's where the virus really loves to spread. On the other hand, you can imagine some people who pay taxes saying, wait a second, I pay taxes, I want to get ahead of all of that group of people. How do we resolve these competing interests here?
Yeah, so I think it's, the congregate settings is about risk, especially in long-term care. And, for better or worse, the decisions we made were not able to protect our long-term care populations. And so putting them at the very top of the priority list absolutely makes sense, because of both exposure and risk of a bad outcome given exposure. The same goes for the very elderly. But after that, what we're finding is it's not so much about who pays taxes, it's about who's at risk of being exposed and being a transmitter. And I think now that we know how powerful the vaccines can be against transmission, so preventing people from getting infected, and then if they're not infected, they can't infect their contacts. What that means is we have an opportunity to get the most bang for our buck of rare, relatively scarce vaccine doses by starting to prioritize essential workers, people who cannot distance at their work. They can't work from home. They have to work in essential services, frontline work, maybe teachers, firefighters, grocery store, food production. We've, of course, seen outbreaks in food processing. These are areas where actually with one vaccination, you can prevent more bad outcomes in those groups because you prevent the bad outcome in the person you vaccinate, but also in a whole bunch of others who don't get infected because you stopped chains of transmission. So I think that's where the conversation should be turning after we finish vaccinating the very most vulnerable.
Isaac, can I get you on that? What should the priority list look like? In what order?
Yeah, great question. And clearly, there's some pretty heated debate on in media and in social media and in conversations because everyone seems to have, and rightfully so, some very strong opinions on this. I think you can approach this through a data-driven lens. You can approach this through an equity lens. You can approach this through public health lenses. And of course, the Venn diagram of those lenses overlaps at some sweet spot. I completely agree with Dr. Colijn that there are strategic ways to vaccinate populations to get the most bang for the buck. I think we have to acknowledge who's at risk of death, who's at risk of having a serious outcome, and of course prioritize that. And that's equity and a public health and data-driven approach. Age is like by far the biggest risk factor, and we just can't ignore that. Now, there's a lot of risk factors for severe outcomes, but age stands above just about everything else. So we clearly have to vaccinate by age, but there's multiple right ways to do this. And for example, you've heard in Ontario, you can look at not just age, but for example, other social determinants of health that could help drive a very equitable and data-driven vaccine program. So if you look at something like postal codes, well, as it turns out, someone who's 50-year-old in certain postal codes has the same risk of dying as someone who's 80-year-old in another postal code. So if you really want to take a data-driven and equity-based approach, you can look at a variety of measures, a variety of mechanisms to vaccinate based on age, based on postal code, based on, and of course, a variety of other factors as well, like Dr. Colijn mentioned, essential workers as well. So what you're going to see from coast to coast, well, I guess we're talking about Ontario. So what you're going to see in Ontario when the plan is hopefully released sooner rather than later, is that the second wave of vaccinations will be prioritizing people who are at greatest risk of having a severe outcome from the infection, but B, as Dr. Colijn puts it, people that are obviously at greater risk of getting this infection, but also of facilitating transmission in the community. And of course, that does include congregate settings as well.
Great. That's a very helpful update, everybody. My thanks to Carolyn Colijn, Nick Taylor Vaisey, and Isaac Bogoch for joining us on the agenda tonight. Many thanks, you three.
Thank you.
Have a good one.
Thank you.
The Agenda with Steve Paikin is brought to you by the Chartered Professional Accountants of Ontario. CPA Ontario is a regulator, an educator, a thought leader, and an advocate. We protect the public. We advance our profession. We guide our CPAs. We are CPA Ontario. And by viewers like you. Thank you.